Good afternoon. I call this hearing to order. Without objection, the chair is authorized to declare a recess at any time. Before we begin, I'd like to ask unanimous consent for our colleagues, Representatives Cunningham, Lewis, Miller, Peters, and Wexton, to participate in today's hearing, should they all be able to attend. Without objection, so ordered. I would like to also welcome our full committee chair, Mark Takano. Thank you for being here, Mr. Chair. Approximately 8 weeks ago, the media began reporting on a string of concerning incidents of patient harm and professional misconduct in VA medical facilities. In August, a former VA pathologist in Fayetteville, Arkansas, was charged with involuntary manslaughter, fraud, and making false statements in an attempt to conceal years of substance abuse. Over his 11-year tenure with VA, he is believed to have botched diagnoses for an estimated 3,000 veterans, some of whom died. Authorities are also investigating at least a dozen suspicious deaths at the VA hospital in Clarksburg, West Virginia. Medical examiners have now determined that 3 of these veterans died of homicide by insulin injection. And early in September, a veteran receiving end-of-life care at a VA nursing home in Atlanta was bitten by ants more than 100 times before facility staff finally moved him to a new room and took action to address this infestation. These reports are sickening. Over the last 2 months, we've also received a steady stream of reports from VA's Inspector General identifying appalling VA quality management failures in several other locations. For example, last month, the IG reported on multiple leadership failures at a VA facility in Vision 10 in the Midwest, which allowed an ophthalmologist to perform substandard surgery and laser procedures for 2 years. This doctor regularly took hours to complete cataract surgeries that should have taken less than 30 minutes. The facility director and chief of staff repeatedly dismissed concerns that were raised by other staff members. Although these 2 facility-level leaders had the responsibility and the authority to remove the provider, they instead chose to disregard the patient safety risks. The reason? According to the IG, the ophthalmologist's spouse was also a surgeon at the facility, and leaders worried that terminating one would entice the other to resign, leaving the facility with 2 physician vacancies. In the end, as a result, several veterans were referred to community care for further treatment to resolve complications arising from this surgeon's care. It would be easy to dismiss any one of these cases as just an isolated incident or just one bad apple. Collectively, these cases speak to wider problems with VA's ability to identify clinicians who are negligent, abusive, or committing criminal acts and prevent them from practicing. The VA's got to do better. Today's hearing will explore several critical questions. What red flags are VA facilities missing, overlooking, or choosing to ignore when they hire and employ clinicians? When concerns arise, why aren't medical center officials investigating in a timely manner? And when concerns are substantiated, why isn't VA reporting them to the National Practitioner Data Bank, the NPDB, and to state licensing boards in a timely fashion? As today's hearings will make clear, far too much responsibility and authority has been placed at the local level. The Veterans Health Administration and its VISNs are doing far too little oversight to ensure that facility-level leaders understand and are complying with policies for ensuring proper patient care and safety. Instead, VA's pervasive lack of accountability is leading to patient harm. That's why we've convened today's hearing. Veterans and their families deserve answers. They need to know that the VA is upholding its moral and ethical obligation to deliver world-class health care. This is the promise our nation made to those who have served, and our heroes deserve nothing less than that. This is not new territory for VA or for this subcommittee. In fact, 2 years ago, General Bergman chaired a subcommittee hearing on this very topic. One of our witnesses, Dr. Gerard Cox, testified at that hearing. Among other things, Dr. Cox promised that the VA would update its policies related to credentialing and privileging, improve the timeliness and reporting to the NPDB and state licensing boards, expand NPDB reporting to nurses and other types of clinicians instead of just physicians and dentists, and establish a new VISN-level compliance process. As you'll hear today, none of these actions have been made since our subcommittee's last hearing on this topic. I'll say that again, the VA hasn't taken any of the actions that it promised during that hearing in 2017. The string of incidents over the last 8 weeks should serve as a wake-up call. No one here would deny veterans deserve any better, any less than that. But we must do better for VA employees who are brave enough to speak up when they're concerned that a colleague's clinical incompetence, their impairment, negligence, or misconduct is putting veterans' lives at risk. As the IG found in the case of the ophthalmologist in Vision 10, facility leaders repeatedly ignored concerns raised by other clinicians at the facility. The indictment of the VA pathologist in Arkansas states that colleagues complained to facility leaders repeatedly that the doctor appeared to be intoxicated while on duty, both before and after he completed an inpatient treatment program. In both cases, it took years for facility leaders to remove these providers, and in the meantime, our veterans suffered. So it's not enough for VA leaders to sit here today and pledge policy changes. They've done that before. We need to see that VA is as outraged as we are, and that leaders at all levels will be willing to walk the walk. We must see a fundamental cultural transformation. Something must be done to make VA a place where employees at all levels feel they have psychological safety and to be able to sound the alarm. Employees need to know that their concerns will be taken seriously, that there's a sense of urgency to address these concerns as soon as they arise, and that VA is acting swiftly to guarantee these issues don't occur again in the future. Their lives depend on it. So with that, I'd like to recognize our ranking member, General Bergman, for 5 minutes for any opening remarks he may have.
Thank you, Mr. Chairman. And as you stated on the front end, in 2017, as chair of the subcommittee, I held a hearing on VA provider competency, which focused on VA's handling of providers who were found to deliver substandard care. Sadly, we are holding another hearing on this vitally important topic in the wake of several new reports of serious patient harm involving VA providers. Our veterans deserve better, and we collectively must give them our best effort because they have given us their best effort through their service. When problems arise, we must take a long, hard look at what went wrong, why it went wrong, and what we can do to mitigate the risk of future failures. The unfortunate reality is that this is a retrospective process. No congressional hearing or legislation can change what happened. It has been said that there are three things that you can never get back in this world: the spent arrow, the spoken word, and the missed opportunity. Mr. Chairman, we have before us an opportunity to significantly improve the Department for veterans and their loved ones. The committee has received several reports recently from the VA Inspector General and the GAO that identified failures in credentialing, privileging, and quality management. It appears to me that there are policies in place that, if followed, could mitigate and/or avoid many of these issues. However, an organization's policies and procedures alone do not make for success. It is the leadership of the organization that establishes the culture, empowers individuals to think and act autonomously, and drives the organization toward a more improved version of itself. It appears that many of these problems are in a large part leadership failures. For example, one of the glaring issues following a recent GAO report was the lack of consistent and standard credentialing, privileging, and quality management oversight from VISN chief medical officers. The report found that the VISN CMO's assessments of credentialing, privileging, and quality of care were often incomplete, with inconsistent use of the, quote, standardized assessment tool, end quote. In fact, some VISN officials stated that they were not using the standardized tool, but rather developing their own auditing tool. You cannot manage what you don't measure. It seems that there is little about the VISN's oversight of credentialing and privileging that is actually measured. Another area of concern that the Inspector General has raised is the lack of direct observation of providers on focused professional practice evaluations, or FPPEs. Instead, VA facilities rely on documents to evaluate the provider's performance. Though documents may show performance to be within acceptable ranges, they may not capture a practitioner's behavior while operating, responding during a crisis, or confidence with a procedure. I am interested in hearing more about this issue from our witnesses. As a military commander, I know that there is always the 10% who are not with the program and can sully the reputation of the rest of the organization. While hundreds of thousands of veterans receive quality health care from tens of thousands of VA providers every day, VA is not immune to this 10% problem. When issues are identified, VA must act swiftly to address them. Therefore, I want to know what VA is doing to correct the identified failures, and most importantly, what it has learned from these failures and what systems and people have been put in place to ensure that VA avoids similar failures in the future. To kind of sum up, the observation is no clear chain of command, no structured review process, and no requirement for direct observation. I thank all of our witnesses for being here today, and I look forward to a productive hearing. And with that, Mr. Chairman, I yield back.
Thank you, Ranking Member Bergman. I'll now recognize our first witness. First, we have Ms. Sharon Silas, a director of the U.S. Government Accountability's Office Healthcare Team. Thank you for appearing with us today, and you're recognized for 5 minutes.
Thank you. Chairman Pappas, Ranking Member Bergman, and members of the subcommittee, I am pleased to be here today to discuss our recent body of work on provider qualifications and competence in VA's healthcare system. My testimony today summarizes findings and recommendations from 2 recent reports on VA's response to adverse information when credentialing providers, and the reviews and reporting of VA providers when concerns are raised about the quality of their clinical care. Based on our findings from these 2 reports, we made 11 recommendations, 9 of which remain open. Like other healthcare facilities, VA medical centers are responsible for ensuring that their providers deliver safe care to patients. VA has processes and policies in place to help ensure that providers have the qualifications and competence to deliver quality care to veterans. First, as part of credentialing and renewing clinical privileges for a provider, VHA policy requires VA medical centers to review the MPDB, which is a database that collects and releases information on providers who, for example, have been disciplined by a state licensing board or other healthcare entity. Review of MPDB reports are used to verify that the provider's medical licenses are current and in good standing. However, in our 2019 report, we found inconsistent adherence to VHA policies that disqualify providers from employment at VA medical centers. Specifically, we found that some VA medical center officials were not aware of key policies that govern credentialing reviews, and that gaps exist in VHA policy that allow for inconsistent interpretation. For example, VHA did not have policies in place regarding DEA registrations and the circumstances in which waivers may be required. Lastly, VHA's oversight of VA medical centers' reviews of adverse information was inadequate. Second, VA medical center officials are also required to review and, if warranted, address any concerns that may arise about a privileged provider's clinical care. And depending on the nature of the concern and the review's findings, take appropriate actions, including limiting or preventing the provider from delivering care to veterans. VA medical center officials are also required to report the providers against whom they take adverse privileging actions to the MPDB and state licensing boards. If VA medical centers fail to properly review, address, and report concerns that have been raised about the provider's performance, they may be exposing veterans and potentially the public to unsafe care. In our 2017 review, we found that for 148 providers that required clinical reviews at 5 VA medical centers, VA officials were unable to provide any documentation for about half of them. In fact, officials acknowledged that in some cases, the required reviews were not conducted at all. Furthermore, VA medical centers did not always conduct reviews of providers' clinical care in a timely manner, some taking longer than 3 months, and in some cases, years to initiate reviews of a provider's performance. We also found that the 5 VA medical centers did not alert the MPDB or state licensing boards if there were serious concerns with regard to a provider's clinical performance, as required by VHA policy. Specifically, we found that only 1 of 9 providers was appropriately reported to the MPDB, and none of these providers reported to the state licensing boards. We found that 1 of these providers was later fired and reported to the state licensing board by a non-VA facility for the same reason several years later. The causes of these deficiencies that we identified in this review can again be attributed to gaps in policy and inadequate oversight. For example, we found that VHA policy does not require VA medical centers to document all types of reviews of providers' clinical care. We also found that while VISN officials are responsible for overseeing the credentialing and privileging processes at their respective VA medical centers, none of the VISN officials we spoke with described any routine oversight. In the last few months, a number of high-profile incidents involving quality and safety concerns with VA providers have been covered in the media. While these cases each have their own specific circumstances, many appear to illustrate the potential impact of the deficiencies we identified in our reviews and highlight the importance of VA implementing GAO's recommendations. Strengthening policies and oversight of VA medical centers' credentialing and reviews of provider clinical care when concerns are raised are key to decreasing the risk that our veterans and the general public will be exposed to unsafe care. This concludes my prepared statement. I'd be happy to answer any questions that you may have.
Thank you very much, Ms. Silas. Our second witness is Dr. John Day. He's the Assistant Inspector General for Healthcare Inspections at the VA Office of Inspector General. Dr. Day, thanks for joining us, and you're recognized for 5 minutes.
Chairman Pappas, Ranking Member Bergman, members of the subcommittee, I thank you for the opportunity to testify regarding OIG's work on the important topic of credentialing and privileging of licensed independent practitioners. I am privileged to represent the OIG's Office of Healthcare Inspections and the staff that prepared the reports discussed in our written testimony. I would like to begin by affirming that our work supports the fact that VHA usually provides quality health care to veterans, and that the overwhelming majority of clinical administrative staff at VA hospitals are committed to their mission. However, it is clear that credentialing and privileging processes, along with the patient safety program and quality assurance, must be improved to provide appropriate assurance that veterans will continue to receive high-quality medical care. In numerous reports over the last few years, my office has detailed incidents where physician care did not meet VHA standards, and episodes where veterans were placed at risk or harmed as a result of too many months of unchecked substandard care. We have made recommendations to VHA to address the lapses in provider credentialing and privileging practice evaluations, and a too-ready acceptance by VHA privileging committees that a provider has the clinical skills and thought processes required to provide high-quality care. We are also concerned that it takes too long for the leadership at a hospital to act to address poor-performing providers. In particular, an August 19 report highlights many of these failures with the Vision 10 Medical Center's decision to hire an ophthalmologist. The individual that was hired was not a board eligible in ophthalmology. The submitted clinical references did not provide comfort that the physician could perform cataract surgery, a surgery for which the physician was subsequently given privileges by the facility leadership. He was not adequately assessed through the FPPE process with respect to the ability to perform cataract surgeries. And when concerns about the quality of this provider's surgical care were raised by nurses and other members of the staff, hospital leadership was far too slow to respond. Simply put, it should not be a challenge to determine there is a problem when cataract surgery that should take less than 30 minutes takes hours, and it should not be a challenge to remedy that problem. While VHA needs to improve their efforts to collect and review all required documents for the credentialing process, more emphasis should be given to understanding the quality of the provider's prior practice through interviews and references from appropriate sources. VHA needs to look for opportunities to adopt a show-me attitude when granting privileges. For example, observing a colonoscopy or reviewing the interpretation of scans and pathology slides should be comprehensively adopted in early stages of a provider's employment. Direct observation of clinical procedure performance and increased use of simulation centers could better demonstrate that a clinician will be more likely to provide high-quality medical care. More concerning to me than the credentialing and privileging issues we uncover is the finding that substandard care was provided for months without VHA leadership action. Technicians and nurses tell my staff that they have no reason to speak up about poor provider care when they see inaction from providers themselves or from facility leadership. I am unsure if providers and staff are not making themselves heard or if leadership is not listening. But this problem speaks to the need to consider changes to the patient safety and quality assurance programs. They must work together to ensure that veterans receive quality medical care. While we generally believe VHA policies are reasonable, it is time for VHA to conduct a serious review of how it implements these policies. Our recent reports should not be discounted as isolated events that would be expected to occur across a large system. In addition to challenging how providers are evaluated in order to reduce variance across the system, VHA should consider appointing a national leader for each specialty whose primary responsibility is to ensure that the quality practice of that specialty across VA is at an outstanding level. A change in how local, regional, and national leaders conduct evaluations and communicate about practitioners who should not be providing care to veterans is paramount given these missteps and delays. Many of the failures we identify can be traced to what is at best ineffective oversight from regional and national leaders. Mr. Chairman, that concludes my statement, and I'll be pleased to answer any questions.
Thank you, Dr. Day. Finally, I'll recognize our VA witnesses. Dr. Stephen Lieberman, the Acting Principal Deputy Undersecretary for Health at the Veterans Health Administration, or VHA. He's accompanied by Dr. Gerard Cox, VHA's Deputy Undersecretary for Health for Organizational Excellence. And finally, we have Ms. Jessica Bongiorni, who is VHA's Acting Assistant Deputy Undersecretary for Health for Workforce Services. Thank you all for joining us today, and Dr. Lieberman, you're recognized for 5 minutes.
Good afternoon, Chairman Pappas, Ranking Member Bergman, and members of the subcommittee. I appreciate the opportunity to discuss the Veterans Health Administration's process for credentialing, privileging, and quality management. I am joined today by Dr. Gerard Cox, Deputy Undersecretary for Health for Organizational Excellence, and Ms. Jessica Bongiorni, Acting Assistant Deputy Undersecretary for Health for Workforce Services. VA is committed to ensuring that veterans receive safe, high-quality health care. We know that some staff do not uphold VA's values, and we will hold accountable anyone that provides poor care or commits crimes in our facilities. Some recent events are deeply disturbing. It is extremely troubling that the actions of a few flawed staff might overshadow the great work of the nearly 348,000 employees who provide quality care every day to veterans and their families. During fiscal year 2019, VA clinical staff and engaged patients more than 121 million times, completed 1.7 million more outpatient appointments at VA facilities over fiscal year 2018, and saw an additional 73,000 more veterans over fiscal year 2018. We are proud that veterans are continuing to choose VA for their health care as the quality of care and access in VA continues to improve. Research studies highlight that the quality of care in VA is better than care in the private sector. The public does not often hear about the overwhelming majority of our patient encounters where VA staff works hard every day to optimize care. Our internal surveys from veterans who receive VA care show that their trust in our system continues to improve, most recently at 88%. As we grow, we are undergoing a transformation into a high-reliability organization. This new initiative to eliminate harm to patients includes remedying the culture in which mistakes may happen. Research confirms that most errors in healthcare are unintentional. Our goal is to embrace a just culture where staff feel comfortable speaking up if something has gone wrong, or could go wrong if a concern is not addressed. This creates a system that reduces mistakes and prevents errors from harming the patient. It is important to note that a just culture still ensures accountability, immediate discipline, and prosecution when appropriate for those who act with maliciousness, willful negligence, or intent to cause harm. VA demonstrated our commitment to that accountability with the recent incidents when staff did not live up to VA's high standards. VA removes people who willfully cause harm from patient care immediately. We learn from the mistakes that cause harm, and we welcome investigations to ensure that we are doing everything we can to create a safe healthcare environment. We have not found a common thread between the recent incidents. Instead, there are a small number of people whom acted inappropriately. VA has a robust set of processes to screen all applicants before they join VA. That includes background screening. For healthcare providers, we follow the Joint Commission standards for credentialing and privileging, including checking with the provider's state licensing board and the National Practitioner Data Bank to determine if an applicant has been reported due to substandard care, professional misconduct, or professional incompetence. VA continues to monitor providers' performance and the external reporting bodies to ensure they remain fit for service, and we react quickly when a new issue is found. Unfortunately, there is no way in healthcare to predict every human failing. We establish strong systems in the way industry standards to respond quickly and comprehensively whenever patient safety might be in jeopardy. In conclusion, I want to emphasize that I am sorry for any pain that any veteran or their families have experienced as a result of our employees acting inappropriately. When something goes wrong, we learn from those experiences. As a result of that, we get stronger. We get stronger because of the nearly 348,000 employees who come to work every day to provide excellent care to veterans. That completes my opening statement. We are prepared to answer your questions.
Thank you, Dr. Lieberman. We'll now turn to questions, and I'll begin by recognizing Chairman Takano for 5 minutes.
Thank you, Chairman Pappas. About a month ago, the full committee held a member day hearing where colleagues presented their veterans policy priorities, and I was alarmed to hear from Representative Womack that VA either failed to provide or was slow to provide relevant information to his office and to other members of the Arkansas delegation after firing the pathologist whose botched diagnoses allegedly contributed to the death or harm of numerous veterans. Representative Westerman submitted a statement for the record for today's hearing that echoes those concerns. And according to Mr. Westerman, VA for months ignored his request to convene an administrative investigation board to examine possible medical center leadership failures. The investigation was convened only after several of the facility's senior leaders, including the director, had retired or quit. I have also heard from members of the Arkansas delegation that VA originally only proposed reviewing the final year of cases handled by this individual. That's right. VA didn't plan to fully review all 11 years of this pathologist's diagnoses until after members of Congress and the IG applied pressure to do so. So, Dr. Lieberman, has VA now finished reviewing all 11 years of this provider's practice?
Yes, they have, sir.
Great. And so how has VA gone about informing veterans whose health may have been affected, who might have been misdiagnosed by this doctor?
They have reached out to every veteran or their family if the veteran was no longer available, to disclose to them what had happened with their loved one.
So approximately how many veterans have been contacted, veteran families?
Approximately 30.
30. And are there more to be contacted? Because we're talking about 11 years worth of cases.
Those are the cases where harm may have occurred as a result of the provider.
All right. I'll be interested to hear more about from your office about how you arrived at those 30 and how you could eliminate all the other cases.
We'd be happy to meet with you to discuss that
Thank
further.
you. Dr. Lieberman, when and how did VA, the VA Medical Center, the VISN, and VA headquarters become aware that at least a dozen, I'm turning now to the question of Clarksburg, West Virginia, at least a dozen veterans died under suspicious circumstances over the course of about a year and a half. How did you become aware? How and when did the VA Medical Center, the VISN, the VA headquarters become aware that at least a dozen veterans died under suspicious circumstances?
So, as you know, this is still under criminal investigation, and we have not had confirmed the numbers. We have not been informed on these specific numbers. We certainly were informed of what had that there was a concern.
I just want to know how you all became aware. How did any of the medical center divisions, how did you become aware?
So the facility had concerns that this was going on and did a review over a year ago, and they informed their facility leadership, who, once they became aware, immediately called leadership at the time in VA headquarters, and then the OIG was immediately notified also.
So my question is it true they only became aware after the IG brought it to their attention? Or are you saying that they became aware before that the IG got involved?
Right before the IG became involved. The IG was notified very soon after leadership in VA headquarters was made.
And how did you become aware of these deaths?
Personally, I heard about it without any details, just that there was a concern of at the facility from the OIG.
And this is after the OIG was brought into this?
So I was not the leadership at the time when the concerns were first brought forward. So when I assumed my leadership role is when I was notified about it.
Okay. So what actions, if any, has VA taken to inform veterans or their next of kin who may have suffered unexplained hypoglycemic events or even death at the Clarksburg VMAC?
So we have not reached out to anyone, as this is an active investigation.
Fair enough. Are veterans and their families expected to rely on the news media for this information?
They certainly have the OIG available to answer any of their questions.
All right, so VA is not, because of the ongoing investigation, you have not proactively made any notifications of the families.
That is correct.
Mr. Chairman, my time is out, and I yield back.
Thank you, Chairman Takano. I'd now like to recognize Ranking Member Bergman for 5 minutes.
Thank you, Mr. Chairman. Dr. Lieberman, according to the VHA Handbook 1100.19, the Principal Deputy Undersecretary for Health or designee is responsible for ensuring oversight of VHA's credentialing and privileging for licensed providers. However, the handbook also says, quote, the ultimate responsibility for credentialing and privileging resides with the facility director, end quote. Can you please help me reconcile who has the ultimate responsibility? Because you are higher in the chain of command, that is, than a medical center director, correct?
Correct, sir.
Okay. Who's at the top?
So ultimately, the Principal Deputy Undersecretary and the Undersecretary for Health have the ultimate responsibility for the organization to ensure that it is done correctly.
Okay, so let me ask you a question. If you're at the top, you know, what are your expectations as they are related to credentialing and privileging? And when was the last time that you personally laid out your expectations?
So credentialing and privileging is a critical aspect of screening to ensure we get the right candidates for our positions. Although there's no perfect way to predict when an employee is going to be problematic. There are many checks and balances in this process. Starts with the HR department actually takes a look at suitability, looks for every employee undergoes a background check, gets fingerprinted, and then the credentialing office begins their part of the review, which is what's called primary source verification, where they double check that whatever the applicant says in their application is correct. And so they will check directly to make sure that they got the correct diploma, the correct training.
Okay, well, you know, you could talk for a lot because there's a lot to do there. We use the example of the cataract surgery taking 2 hours when we know it should take somewhere between 15 and 30 minutes, depending on what type of procedure, whether it's a temporal incision or wherever it is. But the point is, you know, the ASCRS, the American Society for Cataract and Refractive Surgery, as well as other medical disciplines have criteria for performance. Does the VA look to these specialty groups like the cataract surgeons to make sure that in the end, I hear you doing the paperwork, but who's doing the truly the hands-on to make sure that the surgeon can hold the phacoemulsification, handpiece correctly so it doesn't suck the iris out as opposed to the lens?
Dr. Cox, do you want to just talk about that issue?
Sure. Thank you very much for the opportunity to be here today. Each clinical community establishes its own standards for quality, but ultimately, to answer your question, sir, it's the immediate supervisor of that surgeon, right? The service chief in ophthalmology or general surgery or dermatology or whatever service it is that's responsible for assuring the competency and the quality of the practice of the people providing that care in that medical center. And as you heard, there are processes in place for ongoing professional performance evaluation and for peer review to conduct that assurance.
When's the last time somebody got called before a board of their peers for review and was, shall we say, given a thumbs down based on performance?
Well, in the surgery community, the idea of having a sort of peer review or local review of one another's care is commonplace. Morbidity and mortality conferences are routine in every medical facility, including VA medical facilities, to review cases where there's an unexpected outcome or something that could have been done differently, and that's how providers learn from one another and assure the higher quality of care.
And yes, just to respond, peer reviews get a thumbs down, that everyone has the responsibility to do these objectively. And if the standard of care was not met, that is pointed out.
Is there, I hate to say remediation or retraining, again, in my time as a commercial pilot, if you couldn't pass your check ride, you didn't fly the line. You were not certified safe to operate that aircraft, so you had to go back through training, and you got a couple of chances before you lost your job. Is there such, if you will, an exact set of requalification training or standards that will allow people who are good folks, but maybe their skill sets are not up to where they must be to handle surgical instruments? Is there a process?
Well, you're exactly right, sir. It is a requirement that everybody be monitored in this way, and the process depends on the specifics of each case, so each one is handled individually. It may be determined that additional training or retraining is the remedy. It may be a lesser remedy, like more close scrutiny, more frequent oversight, as the Chairman Pappas suggested earlier, having another surgeon directly observe the care of that surgeon under scrutiny in the operating room. And then in egregious cases where the provider's performance can't be improved after additional training or scrutiny of that type, then that's when we get into the question of taking action against that person's privileges, to suspend them or to limit them or even to revoke them.
Well, again, what this committee looks for, subcommittee looks for, is examples of oversight on your part. And these are tough decisions and tough things to have to tell professionals you didn't make the cut. And that there's no pun intended in that at all. I mean, the idea is that you need to get better before we let you into an operating room or into whatever level of care you're providing. Dr. Daig, you have raised to my staff that there is a lack of direct observation of providers when they are under a focus professional practice evaluation, the FPPE. What could be missed if a provider's documents are reviewed, but they are not directly observed?
Thank you, sir, for the question. I think in the ophthalmologist case, I think it's pretty clear that if at the beginning of this individual's practice, one had simply gone to the OR, if they were already a competent ophthalmologist, and observed this individual provide surgery for a day or two, you probably would come to the conclusion this person should not be privileged to practice medicine at the hospital that they practiced. So I think it's a missed opportunity, whether we're talking about colonoscopies or surgical procedures or the interpretation of slides or images, to not test whether an individual new to your hospital with a prior practice coming in to test how well they actually can perform, as opposed to saying, you have wonderful degrees, you've been to great places, we're going to assume you can do this procedure. I think.
Okay, so I know my
show me
time
that.
is up too. Related to a check ride, you just don't welcome a new pilot into your squadron without giving him a check ride first. So thank you, Mr. Chairman. I yield back.
Thank you. I'll now recognize myself for 5 minutes of questioning. I'd like to start with Ms. Silas. One of the things that I hope we can address today at this hearing is the status of the corrective actions that VA promised it would take in our last subcommittee hearing on this 2 years ago. I just want to reflect a little bit on your testimony. You indicated that the GAO made 11 recommendations. Among these recommendations include updating credentialing policies, to establish a timeliness requirement, reviewing quality of care concerns, and to make clear that facilities must document these reviews. GAO also recommended that VHA direct its VISNs to audit facilities' compliance with requirements for preparing credentialing files, initiating and completing timely reviews, documenting those reviews, and reporting adverse actions to NPDB and state licensing boards. Is it true that almost all of these recommendations remain unimplemented? And if so, what are the status in getting VA where they need to be?
Thank you for that question. Yes, out of the 11 recommendations that we've made between the two reports, 9 of those recommendations remain open. The 2 recommendations that have been closed is the recommendation that the VISN Chief Medical Officer document evidence that the VISNs are overseeing compliance with policies. When we did a recommendation follow-up with the Veterans Health Administration in August of 2019, they let us know that VetPro was modified to allow for documentation of the VISN Chief Medical Officer reviews. The other recommendation that has been closed is the recommendation that QSV office should compile and disseminate best practices to the facilities. And the Veterans Health Administration let us know that they had compiled best practices and codified some of those best practices at the time.
Well, thank you for that. It's my understanding that VHA's credentialing and privileging policies, the directive and handbook, were due for recertification at the end of October of 2017. Dr. Cox, I'm wondering if I can ask you, you testified before the subcommittee almost 2 years ago, pledging to update these policies and establish a VISN-level oversight process. Can you reflect on those comments and where things stand today and why we haven't gotten to implementation?
Thank you, Mr. Chairman. I'd be happy to. So since 2 years ago, when I sat before this committee, there have been a number of steps that we've taken to strengthen and improve our credentialing and privileging and quality oversight. First of all, as you read in the GAO report, we completed a review, a focus review of over 70,000 providers in our system who had been improperly, to identify any who had been improperly hired because they had previously had a license that was revoked. That is a prohibition that we corrected. We removed 11 out of the 70,000 as a result of that review, and we reinforced the prohibition by providing additional training for our chiefs of staff and our credentialing officials at medical centers. We developed and piloted that standard auditing tool for VISN chief medical officers. This is now an automated tool that will be fully implemented before the end of this calendar year. It will not only provide a standard for all CMOs to use, but also automatically provide information about the summary of those reviews to the central office, medical staff affairs office that is responsible for these policies. We've strengthened the FPPE and OPPE monitoring practices by mandating that only a specialist from within the same specialty community can review the work of another provider. That had not been standard prior to 2016. Now it is the standard, and that specialty-specific criteria must be used at each facility rather than having a boilerplate set of criteria for those reviews. We also, in cases where there's only one type of specialist, a solo physician, let's say the only general surgeon or the only anesthesiologist, in those cases, we've put policy in place to make sure that their work is reviewed by somebody who is a true peer, somebody in the same specialty from a different facility, rather than having a non-peer from within the same facility, even a clinical supervisor, such as the chief of staff, for example, conduct those reviews.
So I appreciate these steps. When do you expect that these policy updates will be completed?
Well, the policy updates are in progress, and one of the reasons that they haven't been completed is because we are rewriting and expanding them to incorporate some of these strengthening activities. For example, we are separating the credentialing policy from the privileging policy, and in the privileging policy, adding additional information and guidance on how to conduct FPPE and OPPE. In the case of the credentialing policy, we're incorporating requirements now for telemedicine, which add another level of complexity for giving, for assessing the credentials of somebody who might practice in one state, but via telehealth be taking care of veterans in another state. And so I expect both of these will be published by next summer.
By next summer of 2020?
Yes, sir.
Okay. That's well beyond the date that you had indicated in the 2017 hearing. And I understand that these things can take months of review to actually get to the implementation stage.
That's correct.
We're going to continue to do follow-up on that, and I think this continues to be a critical area that requires our attention. My time's expired, so I'd like to recognize the next member for questioning. Ms. Radewagen, you're recognized for 5 minutes.
Talofa, Mr. Chairman and Ranking Member, thank you for holding this hearing. Thank you also to the panel for being here today. Dr. Lieberman or Dr. Cox, VHA Handbook 1100.19 states that the VISN CMO is responsible for oversight of the credentialing and privileging process of the facilities within the VISN using a standardized assessment tool. Would you please explain what this tool is, and what data does this tool provide, and how are these data points utilized in oversight?
So the auditing tool is, it's basically an electronic form that has standard criteria that will be used across all 18 VISNs by each of those chief medical officers. And they'll use it to review any clinical review, any competency review that's conducted at the facilities within that VISN. Just to put this in perspective, Dr. Lieberman mentioned there were 348,000 or so VA employees. 180,000 of them are licensed providers. We have 180,000 providers in our credentials database. Of those, 65,000 of them are independent providers, such as physicians and dentists and advanced practice nurses. So one of the reasons that you don't hear about the 64,990 plus providers that aren't getting in trouble or that aren't providing substandard care is because they are caring and they are competent and they are committed to the care of veterans.
Ms. Silas, in your written testimony, you referenced a standardized audit tool that VA developed to help VISNs oversee reviews of clinical concerns. It appears to me that many of the problems are a result of facilities not appropriately using the tools that VHA has provided. So I'd like to hear your opinion as to what VHA needs to do to make sure that the tool is employed properly.
That is correct. There is a audit tool that has been developed for the VISNs to oversee or at least conduct audits of the VA facilities. What we found was that during our review from 2017, that none of the VISN officials that we spoke with described any type of routine oversight, so they weren't using the audit tool consistently. And so we did make a recommendation that the Veterans Health Administration ensure that the VISNs were consistently using that tool to conduct their audits. Because currently, right now, the VISN or the VHA policy doesn't require VISNs to oversee the directors reporting to the National Practitioner Database or to the state licensing boards, and this could also be incorporated into the tool and help to better ensure that there is oversight of the VA medical centers.
Thank you, Mr. Chairman. I yield back.
Thank you. I'd like to recognize Mr. Cisneros for 5 minutes.
Thank you. Excuse me. Thank you, Mr. Chairman. Thank you all for being here today. Dr. Lieberman, in your testimony, you state that the VA has an obligation to notify state licensing boards of any substantial findings and substandard care performed at the VA by current or former licensed healthcare professionals. However, in instances in which faulty clinicians are still able to practice to the detriment of veterans still occurs. In your opinion, what are the barriers in place that prevent the VA from reporting a clinician to the state licensing board?
I will start, and then perhaps Dr. Cox will have items to add. First of all, when we fail to do something in a timely manner, if we don't any issues with any of the cases we're discussing, we study what went wrong and we identify the problems and we look in the given facility, but then we also look nationally on what we can do to improve it. Often issues involved with failure for this would have to do with training of our staff and making sure that they're aware of the right way to proceed and in the timeliness and how they are supposed to proceed. Dr. Cox?
Well, first of all, let me clarify that reporting to the state licensing board is a separate process from reporting to the National Practitioner Data Bank and with different thresholds. Right? Reporting to the licensing board is done whenever we have enough evidence that there's a provider may have failed to meet the acceptable standard of care and could have put patients at risk. VA has no authority to take action against any provider's license. That authority resides with the licensing board, and so we provide them the evidence that we collect, and then it's up to the board to determine whether to open their own investigation and whether to use that evidence to take such actions such as restricting or removing or suspending a provider's license. The standard for National Practitioner Data Bank reporting is much higher. That can only be done after a complete investigation as well as all the due process that providers do, including a fair hearing where they can present their own evidence and call their own witnesses to defend themselves. And at that point, the National Practitioner Data Bank report is submitted by the medical center director. To answer, I think, a question that came up earlier, it is the medical center director who is the privileging authority and who has the sole and ultimate responsibility for making these decisions. In fact, VA does a pretty good job of policing itself, and the basis for that statement is that over the last 3.5 years, from January 2016 until June of this year, we reported over 1,000 of those 65,000 licensed independent providers to the NPDB. We've reported over 1,000 people in that 3.5-year span. So these actions are taken all the time. They're difficult and complex cases. They require great judicious decision-making on the part of that medical center director, but that's what we need to do to protect the safety of veterans.
So in the 2017 GAO report found that the VA medical centers selected for their investigation did not report any of the providers with the adverse privileges actions taken against them to state licensing boards, despite being required by VHA policy. Therefore, GAO recommended it be required that the VISN's officials establish a process for oversight and ensuring the VA medical centers were reporting providers to the state licensing board and to the National Practitioner Data Banks. My understanding to this date, the recommendation has still not been taken up even 2 years later. So why is this the case, and why are there obstacles that prevent the VA from implementing this necessary oversight?
Well, we agreed with the recommendation that it is the responsibility of the VISN to conduct that oversight. One of the reasons is, as I mentioned, 65,000 providers, 170 or so medical centers, so it's just not feasible to expect that any one person or office in Washington, D.C. can do that. We have regional governance for that reason. Regarding the open GAO recommendations that Ms. Silas talked about, I just wanted to indicate that, across the 2 GAO reports in question, the 2017 report had 4 recommendations, and it is true they're all still open, but it would not be fair to say that they have not been acted upon. That report was published in November of 17, and within 2 months, by January of 18, we had issued additional interim guidance to the field in lieu of a formal policy change, which is still in the works, and took the recommended actions. 2 of those 4 open recommendations have to do with putting this in policy, so they can't be closed until we have published that formal policy, as Chairman Pappas asked me about. The other 2 have to do with finalizing this automated auditing tool for chief medical officers, which we will be rolling out.
Yeah, so I'm running out of time here, but I would like to, if you could, Mr. Lieber, or Dr. Lieberman, sorry, submit for the record, one of the things that you said was training. There was a lack of training as to why this wasn't happening. If you could submit for the record what that training program is and how are we going about training these directors of the medical centers to make sure that these requirements are met, that they do need to report these to the licensing boards and to the National Practitioner Data Bank. I'd appreciate that.
Be happy to do that. And I can just want to reemphasize what Dr. Cox was speaking about. Our VISN chief medical officers take this responsibility incredibly seriously, and they have been going into the facilities and doing direct reviews and auditing, and we see this as really making a difference.
All right, thank you. I yield back my time.
Thank you. I'd like to recognize Ms. Miller for 5 minutes.
Thank you, Chairman Pappas and Ranking Member Bergman, and thank you all for being here today. It is of utmost importance that we continue to provide and maintain the highest quality of care for the men and women who have served our country so bravely. The deaths of Lewis A. Johnson VA Medical Center in Clarksburg, West Virginia, and the sexual assault allegations in Beckley, West Virginia VA Medical Center are not only troubling, but they are unacceptable. As members of Congress, it is our job to support swift and proper investigations to ensure that such instances never happen again. There have been considerable progress that's been made with the quality of care that our veterans are receiving following the enactment of the Mission Act and efforts to address the veteran suicide epidemic. Our service members should feel safe and comfortable seeking care at the VA, and these events show that there needs to be additional oversight of clinicians, proper removal of bad actors, and monitoring of care. The tragic deaths of our veterans at the Lewis A. Johnson VA Medical Center in Clarksburg and the sexual assault allegations at the Beckley VA Medical Center, once again, are unacceptable. We must work together to ensure the families of our nation's heroes get the answers that they deserve, and that we can work to prevent these tragic events in the future. I fully support the investigation into this matter, and I appreciate the committee's interest and oversight. Dr. Lieberman, many of the veterans in my district are extremely faithful to the VA and the quality of care that they receive there. Do you have any suggestions on how we can take VA policies that are made here in DC and ensure that they make it down through the leadership ladder to guarantee that the individuals are aware of the policies and are implementing them correctly?
Thank you for that question. A very important question. So we take this very seriously when we implement policies. We are in the process of modernizing, and that's a big part of our modernization, is to ensure that we're adequately communicating to all levels of the organization. We start at the top and have national meetings, but ultimately it's spread through the VISNs and then down to the facilities. We also have, through our clinical leadership, we expect them to communicate, and we expect the communication to be two-way. We have national calls by specialty, by different parts of the organization, nursing, clinical areas, and we talk about what are the challenges that the field is facing. What are their concerns if we're implementing a policy, making sure we get their input. We don't want decisions to be made always at the top. We want to make sure that we get input from frontline staff so that our policies can be most effective.
I'm glad to hear that. Dr. Day, what are the concerns and/or benefits of incorporating a direct observation policy?
Thank you for that question. I think that the direct observation in many instances allows an expert, for example, going back to the eye surgeon, to observe whether or not it's a go, no-go using the policy, the airline language as to whether a surgeon could actually do that job or not. If you have an individual that you're going to give privileges to do a colonoscopy to, and you watch that person do the colonoscopy, and you see the same images that that person doing the colonoscopy is seeing, you can have a conversation. Are they recognizing the right landmarks? Are they seeing pathology and biopsying it appropriately or marking it appropriately? Did they get to where they want to go, to the cecum, to call it a complete colonoscopy? So I think that by observing and watching an individual do the skills they're being hired to do, you can learn a great deal. There are other areas where it's much more difficult. It's an expensive process, but I think it's one that should be considered and applied much more freely than it is currently in the VA.
If we were to incorporate this policy, what would it look like in terms of staffing, timeliness, and quality of care?
So I don't have an answer to that. I think that that would require work I haven't done to try to figure out what the staffing requirements be or what the actual implementation strategy would be. But by observing and reporting on the cases that we've seen recently, we're seeing evidence now that physicians are making errors that we didn't used to see in terms of making it through the system and impacting a large number of veterans. So I think it's time to consider that we start to look at the quality of care provided at the beginning when we hire someone and do a more forceful job there, observing their practice, in addition to monitoring them with not just paperwork, but with a data collection system that's relevant to the care they provide. So, for example, monitoring how much blood loss a surgeon has during a surgery is important, but that may not really inform as to whether they can do their surgery well.
But it also isn't just the physicians.
I agree. There are many providers in the hospital who well, let me answer it this way. Nurses in general are required to show me that they prove that they can do a skill. You're asked to suction here, suction this. You're asked to put a piece of equipment together to start an IV or to set up an IV bag. Physicians are often given credit for their training and education and experience. And I think there should be more of a show-me attitude as they're granted the privileges to do skills as other people who work in the hospital are often required to do.
because there are many other people that work in the hospitals.
Absolutely.
Thank you. I yield back my time.
Thank you, Ms. Miller. I'd like to recognize Mr. Cunningham for 5 minutes.
Thank you, Mr. Chair, and thank you to each and every one of you all for coming here today. I appreciate it. Dr. Lieberman, in 2017, a constituent of South Carolina's 1st Congressional District, who was also a VA patient with a service-related mental health disability, died by asphyxiation while under supervision of the Dorn VA Medical Center. Are you familiar with that case?
I've heard about it, yes.
Okay. So speaking more generally here, I want to use my time to discuss the VA's approach towards ensuring patient safety in a mental health setting, particularly for those patients who have been diagnosed with a serious mental illness. Can you speak briefly about the policies or safeguards that the VA has in place to protect mental health patients from harm by hospital staff?
We take this very seriously, patient safety. We talk about this. If there is any events that go wrong, we're going to take a look at it and see what happened in these situations. Certainly, if there's suicide, but in this case, it wasn't a suicide. It was
Physical restraint.
Physical restraint, correct. So we look at physical restraints. We monitor for that also under the recommendation of the Joint Commission. We're supposed to take a look at that. We're supposed to minimize use of physical restraint. And when something goes wrong, we have to take a look at it. And our mental health leadership take this very seriously and do look at this and do talk about this in national forums about how we can do better when something goes wrong.
Are you familiar with how personnel are trained under these circumstances when they have an encounter with someone with a serious mental health issue, as was in this case?
I'm not, I would like to take that for the record and get back to you to make sure I get you an accurate answer of all the details, but we do extensive training in this area.
Yeah, I'd like to know some more details about the training and also like who or what department in particular is charged with making sure that the restraint protocols meet certain standards. And you don't have that information either handy, I don't suppose.
Not today, no. We'll be happy to get you that.
Okay. And as far as the personnel, I think you touched on this briefly before, but what processes are in place to ensure the personnel are screened, they're credentialed, and they're retrained periodically to certify that they're aware of VHA policy requirements relating to the safe use of such techniques?
So when we first hire people, we certainly do extensive background checking, doing fingerprinting, making sure that no one has a criminal background. Depending on the level of the staff, if it's licensed staff, we're going to validate that they have the correct licenses. We're certainly going to check their references, important things like that, to make sure that they don't have any history in the workplace showing any concern. And then we go very deep for our providers, making sure that everything they put on their application is accurate. So if there is a lapse in time that they work, why did they have that lapse? Are they physically and mentally healthy? We asked for that, to have a medical recommendation about that.
Okay, I appreciate it. And so you'll supplement the record and provide that information as far as who's tasked with training them and what that protocol is and how often it's reviewed, correct?
Absolutely.
Okay. And, you know, obviously, as we're seeing when our men and women return home from service, so many of their scars we can't see. And this is becoming a difficult issue to deal with, but they deserve the best care that we can give them. And I applaud the VA for what they have done, and we're just seeking the areas in which they can improve upon. And I appreciate your service. And my question to you is, what else can we as members of Congress, specifically this committee, do to ensure that this growing area of concern, men and women with mental health issues, PTSD after coming back from doing so much for our country are awarded the care that they deserve and the care that they need? Are there any other tools from us that you would request?
I really want to emphasize how dedicated, how well-trained, how most of our staff are that do the right thing every day. I have a concern when we just focus on the negative, that it actually harms the veteran who's on the fence about whether they should come to the VA. We have to tell both sides. We have to tell the good stories, because we hear that veterans hear about these issues, which are certainly concerning, and we certainly have to learn from them and improve. But we also have to talk about the quality of care that VA has to offer, and that especially for mental health care. And I apologize for what happened at Dorn. That was a very upsetting and issue there for that particular case. But we have to get our veterans to be willing to come to us, and I just get worried when we just focus on negative in forums that it's harming the veteran.
Yeah, and I would say in Charleston, we have a 5-star facility, and very proud of that facility there in Charleston. I think overall that's the impression there. And unfortunately, though, we do have to focus on some of the terrible situations we're confronted with and how to make things better and to ensure that they do not become a pattern. And I think that was the purpose of being here today. So again, I thank you for your service, and each and every one of you all, and I would yield back.
Thank you. Mr. Peters, you're recognized for 5 minutes.
Thank you, Mr. Chairman and Ranking Member Bergman, and also thank you for letting me weigh on this committee. I was pleased to serve on it in the last Congress, and as a San Diegan, I really want to say how much I appreciate the work you all do and appreciate your commitment to our veterans. I also want to acknowledge that there's a lot of fine work going on at the VA, and the nature of our business is that as oversight, we're going to look at some of the things that aren't going as well. And I wanted to come today just to get into a little bit of a troubling story from the San Diego VA. I recently detailed this story at the VA Committee Member Day last month, but wanted to summarize the story here. The San Diego VA participated in a study examining alcoholic liver disease, which was one site among other institutions of a larger NIH-funded study led by the Pittsburgh Liver Research Center and UNC Chapel Hill. 9 patients diagnosed with alcoholic hepatitis received transjugular biopsies, and according to whistleblowers' disclosures, this was not the standard of care, and reported this to the VA's Office of Medical Inspector, or OMI. Following OMI's report, the Office of the Special Counsel, or OSC, conducted an independent investigation and found that the VA's internal report was unsatisfactory. The Special Counsel report alleges that these samples were collected improperly, sometimes without patient consent, and could have put patients in harm's way. Not that there was evidence that anyone was harmed, but that was their conclusion. The Special Counsel urged the VA to revisit its findings in the matter and take a truly critical look at the research being conducted at the San Diego VA. Now, we know this is not the first time that OMI has investigated wrongdoing and has come up short in answers, according to the Special Counsel. According to data provided by iNewsSource, which is a San Diego news outlet who's broke the story, when the Office of Special Counsel reviews OMI report, 16% of them are found unreasonable, which is more often than other executive agencies. My colleagues here will remember the clinical neglect at the Manchester VA, which has been mentioned. The Special Counsel also find OMI's reports in that instance to be unsatisfactory. Again, no recorded cases of risking patient safety in this instance. This story presents a case, though, that could have consequences in other settings, especially for VA medical centers that conduct research on site. We want them to do that. We want them to pair with academic institutions. So my goal is to strengthen the investigatory bodies that handle these types of allegations so that these things don't come up. And Dr. Cox, maybe I'll ask you, since you served as the director of the Office of Medical Inspector, how often does OMI review and report on medical research issues like these?
Thank you, Congressman. I'd be happy to answer your question. First of all, it is not often that the Office of the Medical Inspector is involved with research oversight. VA is unique in having a separate and independent Office of Research Oversight, ORO, which participated with the Office of the Medical Inspector in that San Diego review. And if I may, I just would like to clarify the sequence of events that you described about the liver research case. The 2 whistleblowers at the San Diego VA Medical Center, to whom we're very grateful for bringing these concerns forward, went to the Office of Special Counsel, right? They asserted themselves as whistleblowers with OSC. Through the standard statutorily guided process, the Special Counsel of the United States referred the matter to the Secretary of VA, who then assigned it to the Office of the Medical Inspector for investigation. OMI does dozens of these whistleblower investigations every year, and they are part of our independent internal assurance and oversight capability, that they are the entity that can go into any VA medical center and conduct an investigation and collect evidence to determine whether the whistleblower's allegations are substantiated or not. As you indicated, when OMI did the initial report, the initial investigation and wrote a report of that investigation at San Diego, they failed to substantiate the whistleblower's concerns. And the reason for that, it later became apparent, is that at least one key witness was not truthful, was not forthcoming with information that when we later found out about that, ourselves took it upon ourselves to go back, conduct a second visit, a second investigation. This is after OSC had closed the initial case and said it was not reasonable. And we, on the second occasion, substantiated those findings, substantiated that there was egregious research misconduct, and voluntarily submitted that second report to the Special Counsel of the United States. They are now considering it.
Great, I appreciate that. And in general, do you think that OMI has enough resources to thoroughly handle whistleblower complaints?
I do. You mentioned the iNews Source article, and we were able to answer questions from the investigative reporter before she published that article. And we conducted our own analysis of the rate at which the Special Counsel of the United States finds OMI's reports not reasonable. And we came up with a very different number. She asserted 16%. Our number is about 5%. That track record actually has substantially improved since 2014, when the Office of the Medical Inspector was restructured, and we added additional staff since then, so I believe that the staffing levels are now
I'm out of time, but to the extent you'd like to supplement your answers in writing, I would certainly appreciate that. Again, appreciate you all being here. Thank you.
very happy to. Thank
I
you.
yield back.
Thank you. I'd now like to recognize Ms. Wexton for 5 minutes.
Thank you, Mr. Chairman, and thank you to Mr. Chairman and Ranking Member for allowing me to participate in today's hearing. I represent Northern Virginia here in Congress, and my district begins just outside of Washington, D.C. and goes about 100 miles west all the way to West Virginia. And so veterans in my district, because we don't have a VA facility of our own, they have the option of either going east into the D.C. VA or west to Martinsburg. So both of these facilities are in VISN 5, and so these, obviously the allegations or the substantiated issues at VISN 5 are very important to me and to my constituents. I was really troubled to learn about the deaths at the Johnson Medical Center in Clarksburg, West Virginia, and the sexual assault allegations at Beckley, West Virginia's VA Medical Center. And I'm very concerned about the serious allegations of wrongdoing by medical personnel at the VA facilities in Arkansas and Georgia. Our veterans have sacrificed so much for our country, and they deserve the highest quality of care. And at a minimum, they should feel safe in our VA facilities. I think we can all agree about that. And unfortunately, these facilities have failed on both counts. So with the benefit of hindsight, we are able to see some of the things that went wrong, but what I'm hoping we're able to do with today's hearing is make sure that we have the protections and protocols in place to make sure that these things don't happen again. I'd like to focus for a moment on the role of VISNs in oversight of wrongdoing at these VISN 5 facilities. There have been reports, Dr. Lieberman, that VA employees are hesitant to report suspected wrongdoing in these and other incidents. And I was pleased to hear you talk a little bit about, from top down, but also from bottom up to make sure that the reports are made. Are VA employees trained on the appropriate chain of command in reporting suspected wrongdoing at the VA Medical Center level?
So thank you for that question, Congresswoman. This is a really critical issue, and that is why we are undertaking this high reliability organization journey where, as a part of being a just culture, staff feel comfortable coming forward. They're not concerned that they're going to get in trouble for this. And so we are working on this. And at the Atlanta facility, one of the biggest failures with that unfortunate case was the culture there was such that it did not come up the chain of command of what was going wrong there. And as a response to that, we really emphasized in a variety of different forums, including Dr. Stone, our executive in charge, sent out a letter to every employee talking to them about the importance of that they have an obligation, a responsibility to speak up when they see an unsafe situation, that we will protect them if they come forward. Certainly, if some employees will never trust their leadership, and so we always have the backup. There are hotlines for OIG, we have a compliance hotline, OSC, so there's always that, but really we want to get to the point in our own organization where everybody feels comfortable in speaking up.
And it would also be good for them to feel comfortable that their complaints will make it up the chain of command and be acted upon, and they will find out what the results of the investigation.
Absolutely, and so we have to lead by example and show them that they're making a difference in the workplace when they speak up.
Thank you. Ms. Silas, I was pleased to hear you talk about the GAO's 11 recommendations and ones that are being implemented, and particularly with regard to the standardized audit tool. Now, am I to understand from your answer to an earlier question that there are issues with the tool that is being rolled out right now? Is it lacking in some way?
No, I wasn't commenting that there was an issue with the audit tool. We're still waiting for validation that the tool's been rolled out.
Have you had an opportunity to see how this tool works?
I have not personally had an opportunity to see how the tool works.
Has someone with GAO had an opportunity to see how this tool works?
Yes, the team that conducted the review had opportunity to.
Is it your understanding from that team that the tool that is going to be implemented will address the oversight concerns that were announced in the report?
Yes, that's correct.
Okay. And Dr. Cox, I guess you were talking about the fact that this tool is going to be rolled out before the end of the year. Is that correct?
Yes, ma'am.
And what kind of training do you have for staff in order to ensure that they are properly using the oversight tool and that it will be a part of any sort of initial intake?
Training of both the chief medical officers at the VISNs, who are going to be the primary ones to use this tool, and of the credentialing officials at every VA medical center is a part of the implementation strategy. So that's built into the rollout process. So the tool was developed, it's been piloted. There were, as with many new electronic things, some IT glitches, so we had to step back a little bit and fix those bugs, and that's the reason that it hasn't already been implemented, but it's on track to be rolled out this year.
And you expect that for the year 2020, it will be fully operational and be used in the entire facility all throughout the VISN?
We do.
Okay, thank you very much. I see my time has expired. I appreciate it. I yield back.
Thank you very much. I just have a few additional questions before we close, and I'm wondering, Dr. Day, if I can ask one of you. In your testimony, you talk a little bit about the decentralized nature of VHA and how this places significant responsibility, if not all the responsibility, in the hands of local leaders to ensure they're employing highly qualified, highly competent professionals. But time and again, your teams have discovered that leaders have failed to carry out certain responsibilities related to reviewing the quality of care concerns and taking action to limit or revoke privileges and reporting clinicians to licensing boards and the NPDB. So in your opinion, should all of these responsibilities inherently reside at the local level? Do we have that balance right? Or is there an opportunity here to get VISNs and VHA more involved in the process?
I think that VISNs and VHA should be more involved in the process. I think that sometimes there's a lack of knowledge as to what an evaluation would be that's proper. So if you hire a medical specialist who's the only person in the hospital who does that specialty, the chief of staff may in fact know very little about the technical aspects of that job. So I think getting larger involvement or more specific involvement by national leaders would be important.
Thank you. Dr. Lieberman or the VA, would you like to comment on that at all?
I think we are moving in that direction. As we mentioned before, the chief medical officers are having much more involvement with oversight and auditing of the process, as well as our national offices are. And certainly, a lot of the suggestions that Dr. Day has mentioned, we are taking under serious consideration, taking a look at.
Okay. Dr. Lieberman, one more thing before we close, and this has to do with the situation with the pathologist in Arkansas. One of the things that really doesn't sit well with me is that this individual completed a 3-month inpatient rehab program and then was returned to his position as the chief of pathology. He went on not only to conceal his continued impairment, but was also changing recommendations, and he was believed to have falsified veterans' medical records in that process. So I'm wondering if you could talk broadly about the acceptability of an individual returning to a supervisory position. Shouldn't we have individuals watching this person's work as opposed to this individual being tasked with watching the work of other folks?
Thank you for that question. So in this country, about 10 to 15% of American citizens will have a problem with alcohol or other forms of substance abuse during their lifetimes, and that's no different than healthcare providers. It's an unfortunate fact, but that's part of our society. It has been shown that for physicians that they actually have a very high long-term success rate with rehabilitation. Upwards of 80 to 90% abstain from alcohol, and it's thought that those individuals truly love what they do in their careers, and they are committed to this, and they are successful. So in healthcare, in society, individuals are given a chance. This individual went through rehab. Most people who go through rehab will not, if the allegations are true about what the OIG has said about this individual, this person was very trained and skilled and found a substance that most people in healthcare have not even heard of, and knew that this could cause intoxication and also would not be detectable on screening. And so I was not there or not involved with the decision, but certainly one could look at the decision to immediately put this individual back as the service chief. You might have decided to observe them in a non-leadership position for a while just to confirm. But again, this individual was getting repeated alcohol tests, and they were turning out to be negative. And so there were no obvious warning signs about that initially.
Well, I certainly believe in second chances, and supporting an individual's recovery is crucial, especially in the workplace. But I think that additional steps should have been taken in this case. I'm wondering, Dr. Day, if you have any thoughts on that particular case.
So I'd like not to talk about the case at hand, but talk more generally. I certainly do believe in second chances. I do think, though, when someone has a physical impairment or a mental impairment, be it hepatitis or drug abuse or substance abuse, and they're brought back on to practice medicine, that there should be close oversight of the quality of the work they do. Whether or not they're a manager or not, I think that's more of a local decision. But I think that the care they provide post whatever the event was ought to be critical and be focused.
Well, thank you, and thank you to our panel. I'd like to see if General Bergman has any additional questions or if he'd like to close.
The answer is both.
Okay.
One quick question. Ms. Bonjourney, you've been sitting there very quiet and patient for this entire time. I noticed that in your bio that you are certified both in human resource and project management. It's my understanding that there are organizations that certify credentialing specialists. Does VHA require credentialing personnel to be certified? And if not, has VA explored the benefits of requiring certification? And if so, what did it find?
Well, thank you for your question, sir. I do not believe that we have explored that, but we are actually in the beginning stages of a process to look at the organizational structure and the position and career path for people who do credentialing work within VHA. So that's absolutely a concept that we could explore to determine whether that would make a significant positive impact.
Well, you know, we're all here. You know, several of us have used the word just recently within the last minute or so. We believe in second chances. We also believe that if we have to look inside ourselves as an organization and what is it we're trying to achieve, and are our tactics, techniques, and procedures or processes that we would use for ensuring that, number one, the best quality outcome for the veterans. And that starts with providers who are credentialed, certified, recertified from time to time to ensure that they're up to standard. So, and I'd just like to, if I can just incorporate my closing into this, Mr. Chairman.
Sure.
Again, thanks for the hearing. It's been about 2 years since I chaired the subcommittee hearing on this topic, and I guess to say I'm not troubled would not be true. I am troubled that we continue to have the same conversations about leadership and policy implementation. We can and we must do better. I intend to work with all of you and all our other witnesses to leverage your experience, because you're where the rubber meets the road, to leverage your experiences, your responsibilities, to improve VA's processes for credentialing, privileging, and quality management. That said, I'm encouraged by the fact that several of the incidents referenced today reached OIG through VA employees who were willing to stand up and call out what they believe to be substandard care, substandard practicing, if you will. We've had a series of hearings on the process for VA staff to report serious concerns, and with another one on the horizon, I want to take a moment just to thank these individuals who have utilized the system to bring attention to these serious, serious issues. And with that, Mr. Chairman, I yield back.
Thank you very much, General Bergman. Thank you as well to our panel for being here today. I think it's critical that we understand that we're all looking out for the veteran, the end user of the care offered by the VA, to ensure that it is top-notch and ensure that their health safety is always protected. Veterans need to trust that the VA is fulfilling its responsibilities for credentialing and privileging. And they also need to know that this department is taking appropriate action to investigate concerns that arise about clinical care and remove clinicians who deliver substandard care or engage in misconduct. We as a subcommittee have a duty to ensure that VA fulfills all of its responsibilities. And unfortunately, I think today's testimony means that we have some more work to do. And I am committed to working alongside General Bergman and to the members of this subcommittee, as well as our congressional colleagues on both sides of the aisle, to continue our oversight work and to continue to encourage the VA to be moving in the right direction. So I thank you for all of your efforts. I thank the workforce at the VA and its providers for the care that they offer for our veterans day in and day out. And I just hope we can continue this conversation and continue to understand that there's a sense of urgency that is there for our veterans to make sure that the steps that have been outlined today are implemented as quickly as possible. Members have 5 legislative days to revise and extend remarks and include any extraneous material. So again, thank you all for joining us today, and without objection, the subcommittee stands adjourned.